I thought I'd start with my life as a doctor. I was a doctor for 15 years, and my first job was in A&E in Dublin, in Ireland. I don't know if we have any Irish people here, but you'll recognise the accent, presumably. Just you, that's the only representative we have. And being an A&E doctor as one of your early jobs is really tricky. And I remember turning up on my first day in A&E, and they're never scrubs that fit you. That's the first thing. And I remember the scrubs were extra, extra large, as some of you seem to be nodding. And I felt like they were blue scrubs, and I felt like I was walking into A&E sort of like a small blue dolphin in a big blue dolphin costume as I walked in. And the first thing that hits you is the noise that comes from A&E. You've got also the sort of smell of industrial disinfectant, but you also have the noise, this wall of sound of people talking, of course. You've got patients and nurses and doctors and so on. You've also got printers printing and faxes faxing, and it's just a busy, busy place. You often see on American shows people talk about, get me the fluid stat, but that doesn't really happen in Ireland. It's more like one of the nurses says, Brenda, would you ever get me some fluids? And you get the fluids. So it's not that dramatic, but things actually happen at the same pace, if not quicker. And in all that chaos and confusion as a junior doctor, I remember thinking to myself, how am I going to find some way out of this, some sort of organization of this? And in the eye of the storm, really, was this box on a wall. And the box on a wall is a wooden box. It looks a bit like a mailbox, so it's like an A4 size, and it's open at the top. And it's open at the top because the triage nurses put a piece of paper in there. They put a blue or yellow piece of paper, as it was in that hospital. And on that paper are, let's say, your name, your age, and so on, and a basic, what we call a presenting complaint, so whether you've got a headache or something else, like chest pain. And also, on that piece of paper is a sticker, and the sticker is either red, or it's orange, or it's yellow. Depends on the A&E. The one I worked on had a slightly different system, so perhaps more common. And I want you to imagine what you came in with. So I'd go over to that box, and I'd pick up whatever the yellow piece of paper was. And if it was red, I knew, okay, we're talking serious stuff. This person could be in resus, it could be a stroke, for example. If it was orange, could have been maybe chest pain, but the heart tracing was normal, so perhaps there wasn't that much drama going on. We weren't quite sure. And if we were green, which was the colour we used in this A&E, it usually meant it was fairly mild, hopefully. So perhaps you had been, I don't know why I'm looking at you, but perhaps you've been trampolining and you should have known better, or perhaps you were skateboarding and I'm looking at you and you should have known better. And so you had a minor injury, but the hope was that you would be okay. And that triage system was really one way of finding sort of some calm, even though there was chaos and confusion. I do remember, if you're looking for a good sense of humour, Irish nurses, it just does not get better than A&E. And I remember there'd be a tannoy, there'd be a sort of tannoy system from the resus room. And the nurses would say, for example, red in resus, and you'd run in because you knew you had to run in really quickly. And there was a doctor I worked with called Lizzie, and she was particularly fast. She was the Usain Bolt of, doctors, compared to the rest of us at least. And I remember the A&E nurses, there was a sort of tannoy announcement, and it said, orange in resus, and she absolutely legged it into resus. And she got there, and she pulled back the curtains, and there was just an orange. They just left an orange on the bed, and that was the orange in resus. So that was the kind of sense of humour amongst, obviously, the very severe things that were happening. But the way you really get a handle on things when you're in A&E and you're in resus and it's terrifying is to try and reach a diagnosis. Because if you think about it, if you came in with a headache, let's say, and I told you it was a migraine, that means you can ring home and you can say, okay, it's a migraine, I thought it was something else, at least there's some sort of treatment for it. Or let's say you came in with chest pain. I could tell you this is a heart issue, and you could also ask me questions about this specifically, like a myocardial infarction or a heart attack. Hopefully you'd be well enough to talk about it. And I could ring the cardiologist and I could say, well, this is what we're talking about. So the diagnosis would be really useful. And of course, sometimes we get diagnoses wrong, and sometimes it takes too long to get to the diagnosis, but they do help. They help us to explain our own symptoms and to explain them to others as well. So I had no reason really to doubt diagnosis, and I went and became a neurologist, and I moved here. I worked at the Royal Free in Hampstead, and I made diagnoses, things like migraine and stroke and epilepsy, and it seemed again to be this great organising force. And as part of my work, I go to Mozambique every year, and I go to a place called Beira. I don't know if any of you have heard of Beira, but it's a port city in Mozambique. And the hospital where I worked and go every year, the life expectancy is about 50 or 48 to 50. And most of the patients there have HIV and or TB, so 80%. And I saw a woman called Joyce. Joyce was in her 60s, and she'd had TB, but it was now, or tuberculosis, but it was now quiescent. She was completely well from that point of view. But she came in and she had aches and pains, and she felt dizzy. She had difficulty walking. And we were trying to figure out what was going on. And as I said, her tuberculosis wasn't an issue, actually. The tests from that point of view were okay. And she had these physical symptoms where she had pain and she felt dizzy. And we couldn't explain them with the tests. It wasn't showing up anything. And so we went and we looked at some other factors and we talked to her a bit more. And it turned out she had this history of trauma. So she had endured forced labor during the Civil War. And the diagnosis you or I might have made would have been PTSD. And I thought that was a reasonable diagnosis. You know, she had this history of trauma and now she had these physical, psychological symptoms. But it transpired the diagnosis was actually made, or the label or the description was actually made by a healer in her own village in central Mozambique. And that was that Joyce had been possessed by a spirit. So there's these spirits called Gamba in Mozambique in her particular community, and they arrive from the time of the Civil War, really, and they possess the bodies of people from opposing sides to their own families. And what they're really trying to do is seek revenge, to seek justice in other people. And I know we often hear about spirit possession, particularly in women, being a very pejorative and dangerous thing, but in her particular community, that was not the case. And so the idea was that she would have a healing ceremony and she would be healed. And I began to realize if I had said PTSD, that would have undermined her experience. It would have sent her down a road maybe of therapy or tablets. And actually what was going to happen was you were going to have this situation where she was going to have a healing ceremony. Families on opposing sides of the Civil War would come together and acknowledge their wrongdoings and seek forgiveness. And that would be the way that she would heal. So PTSD would have been a really silly diagnosis to give her and one that undervalued the cultural currency of her experience. So I began to rethink the diagnoses that I made back here in London and the ones that I'd made before back in Dublin. And what I want to do is walk you through some of those diagnoses today. I'm going to tell you the stories of 3 people. They are Jeremy and Hector, and later on I'll talk about Mikey as well. And it means these are the stories that have really shaped my understanding of diagnosis and hopefully might shape yours as well. So the first story I'm going to tell you is of a man called Jeremy. And I think I've got a picture. Yes. So this is Jeremy. Hopefully you can see him. Jeremy is a man from Ulverston by the Lake District. And he's a stone waller, so he builds stone walls, dry stone walls. And with him you see Timmy the dog, and you can try and identify what breed of dog he is. Can anyone identify the breed of dog? Told by Jeremy he is part collie and part fox. And I'm not quite sure if that's true. But the really useful thing about Timmy, Jeremy says, is that when Jeremy has gravy with his dinner, Timmy is really good, apparently, at sort of licking off the gravy. So that's one of the many qualities that we like about Timmy. The story of Jeremy begins when he was a school child. So Jeremy went to a very Catholic school, and he came from a very Catholic family. And this was Jeremy in his younger days. And when he was 14, he fell in love with a boy called Stephen. Stephen felt the same way, so they had a relationship, but of course they didn't tell anyone about it. And as Jeremy headed towards his A-levels, it became obvious, I suppose, that he was going to go to a different university from Stephen. And this was a realization that hit him. It was devastating, and it hit him really suddenly. And he described to me how he sort of walked up the corridor at school, and then he crumpled and sank to the ground, and he started crying. And a priest came up and said, "What's wrong?" And Jeremy said, answering that question truthfully was the worst thing he ever did. So he said, "I'm in love with Stephen," and waited for the response. And the response was a priest took him to Monsignor Sweeney, who was the head of the school, and Monsignor Sweeney sent him straight to the doctor, the family doctor, and then straight to a psychiatrist. So within days, Jeremy was walked by a priest to a psychiatrist at Mount Linfield Hospital, and Jeremy has all the records, so we were able to look through those letters. He remembers being walked into a sort of dressing room area or treatment room. And initially he was told to put on a dressing gown that was too big. And he was 18 at this point, by the way. It was 1972. And he was wearing slippers, but they were too big. So they sort of made this flip-flop noise on the ground. And he was led into a treatment room and he was put in a wooden chair and his arms were strapped to both sides of the chair. And he was shown pictures of naked men and naked women. And he was also hooked up to an electric shock machine. So every time he was shown pictures of the naked men, he received an electric shock. And this treatment went on for 90 minutes, and it went on for months. Stephen eventually ended up going to that university, and it was Jeremy who was punished. Jeremy went on, he failed his A-levels. Obviously, he was absolutely distraught and in chronic agonizing pain. And when he failed his A-levels, the priest sent him back for more electric shock treatment at Mount Linfield. What I want to do is try and understand how Jeremy ended up in that chair. How did he end up receiving that treatment? Because it seems, it's just incredible to us now that that could happen. And could it happen again? And I also want to think about what the consequences of that are. And I want to tell you a bit about Jeremy today as well. So to try and explore this, I ended up trying to figure out where all this terminology came from. And actually, the word homosexuality was originally a call to action. That's what the term was. So there was this Hungarian journalist who wanted to essentially fight for human rights, and he used it in view of that. But it was commandeered by the medical profession, and the idea was that they were looking at this as something that could be cured. And you had in the background a sort of change in terms of the religious establishment. You've got this move towards secularism, and you have demonic possession is now insanity, for example, and drunkenness is alcoholism and addiction, and sodomy becomes homosexuality. And the psychiatrists of the time would say they were trying to help people rather than seeing people as sinful. They were trying to help them and to heal them. And so that's how the terminology got commandeered to homosexuality. But what really gets a diagnosis into our systems is if you get it into the classification manuals. So you might know there are classification manuals from the American Psychiatric Association, and they included homosexuality in their manual in the 1950s. And the World Health Organization included homosexuality as a condition of psychiatric deviancy or social deviancy also in the late 1940s. And homosexuality remained a psychiatric diagnosis until 1990, recognized by the World Health Organization. So I wondered what happened here, because I don't think most psychiatrists here at the time were necessarily reading the American Psychiatry Association manuals at that time. So I went back and I went into the archives and I found some minutes of the meetings of the British Medical Association. So there was this series of meetings, and I want to sort of take you back there. So it's a 30-minute walk from here. It's a December day, so I want to imagine you're cold if you can on a day like today. And it's early December, and it's 1954. And if you head to that building, you need to go up Savile Row and then Regents, and then I think you go up, I'm not good at directions, but Tottenham Court and then Goodge Street, and then you get to Tavistock. So you're standing outside this window, and through the window on this cold day, you're seeing 10 doctors, and they're meeting there for the first time. They're going to meet there every week for quite some time. And they have been asked to report to the Wolfenden Commission, which many of you have probably heard of. It was a commission set up by the Conservatives to look at the legality of two things, homosexuality and prostitution. And so these doctors were asked, as I said, to file a report and to tell this commission what they thought in terms of the pathology of homosexuality, what they think should be done. And they put together this report, and in order to do so, they got experts to come into that room that you're looking into. And the experts presented all sorts of research on homosexuals and the arm span they had and the tone of voice and whether their hormones are up or was there a deficit of certain hormones. And at the end, they produced their own report from this room at the British Medical Association. And the report said, in no uncertain terms, that homosexuality, it was a condition of deviance. It on occasion needed very significant treatment. And sometimes moral encouragement would do, but also some people would need more interventions than that. And the phrases they used in the terminology, they talked about people who were inveterate and degenerate. They talked about some people needing to be put in psychopathic colonies and to be referred to as inmates, and never to be allowed out until there was evidence of sound reformation. As it happened, Wolfenden here didn't actually agree with that and said in the end that it shouldn't be seen as a medical condition. The problem was this was obviously a very influential report amongst medics. And it meant that many of the people who did research and delivered the electric shock therapy that I'd mentioned and the drug therapy that you may have heard of were very much spurred on by the report that was produced by the British Medical Association. And it's important to say, so aversion therapy is a term you may have heard. You may have heard it in the context of conversion therapy more recently. Aversion therapy was when people were conditioned against acting a certain way. And that could be, for example, through electric shock treatment, or it could be through drugs when they were shown pictures, for example, in Jeremy's case, of naked men. And aversion therapy certainly wasn't mainstream, but it wasn't fringe. There were big treatment hubs, and we know hundreds of men were treated in this way. There were treatment hubs, for example, in Manchester, in Liverpool, in Glasgow, in London, in Belfast. So it certainly was across the country. And these were stories and success stories that were reported, for example, by The Observer and The Guardian and The Times and The Scotsman. So, you know, these were success stories that were certainly reaching national media and mass media. These practices went on for some time, and of course it meant when Jeremy walked into that room that day, his psychiatrist had some sort of legitimacy because the diagnosis really sanctioned the treatment that Jeremy received. And he was obviously one of many who went on to receive that treatment. In the end, thankfully, things changed, and homosexuality was removed from the American Psychiatric Association manual. It was removed in the 1970s, and that was because there was lots of human rights movements and civil rights, and most importantly, there were activists who were LGBT activists and also psychiatrists who realized there had to be another way. And so homosexuality was removed as a diagnosis, but that didn't happen in the World Health Organization, as I said, until 1990. Now, we know that has left a legacy because conversion practices often draw on that aversion therapy and terminology. I want to tell you about what happened to Jeremy. So, although obviously he was very much let down by the profession in those early days, he eventually found a therapist and psychiatrist that he could trust, and he eventually was able to come out to his family and to his friends. He was estranged from his parents, who it turned out had known about this electric shock treatment the whole way along, although he was told not to tell them. And he has written a memoir, Is It About That Boy? And in it, he talks about how he's come to terms with things and can at least start to talk about them now. He, as I said, builds dry stone walls. And in 2 weeks' time, I'm going to go and build dry stone walls with him. We've had to put it off because of the pandemic, but that's where I'm going. Let's take us back to triage now, and let's say we're back in A&E, in this Dublin A&E, and we are triage green. So it's fine, you've just been trampolining and you've just been skateboarding, but it's not too bad, you're getting seen to. And one of the things that struck me when I was writing this book, which I've just seen there, is that diagnoses, we look at some diagnoses now from the past and we think, how on earth did we take them seriously, you know? And I wonder, will we one day look at our diagnoses and think exactly the same thing? There was one diagnosis, for example, a Victorian diagnosis called spermatorrhea. I don't know if anyone's heard of that. And it's, as someone who went to convent school, this is quite shocking, or rather I was sent to convent school. But spermatorrhea was a diagnosis in the 19th century where men believed they were producing too much sperm, and they would go to doctors as a result of that. And there are some fantastic descriptions of why this happened. And the triggers were usually believed to be masturbation. That was a major one. And another one was flannel, and another one was thunderstorms. And the fantastic thing, I've got some great quotes in there, and one of them was, "One unfortunate soul ejaculated twice on the train from Brighton to London because he sat instead of standing," which hopefully is not something we worry about today. These diagnoses were, again, subject to all sorts of forces. Why did they happen? It seems ridiculous to us now. But actually there were forces. There was this moral panic about masturbation before this diagnosis came along. And also the quacks and the charlatans were out and they really wanted to treat it. And the medical establishment were saying, hang on, we've got this. And the surgeons came forward it was a land grab, really, and said, look, we've got the surgical instrumentation. I can see people wincing. We've got the surgical instrumentation to try and address this. And it was just at the time where the medical establishment was being registered, the General Medical Council had been set up, and so they needed to say, we've got a definite diagnosis that we can work at that differentiates us as surgeons from, for example, the quacks and the charlatans. There was another historical diagnosis that I write about called chlorosis, and these were particularly women. And these women often were said to look quite green and melancholy, and they had menstrual disturbances, and it was really common. So Finsbury Dispensary in 1800, 6.4% of women who went there got this diagnosis. It was really common. And the treatments were also, let's say, of their time. So women, for example, were told in the earlier centuries not to wear corsets. Later on, they were told not to read too much, not to write, not to think too much. And rather conveniently, I saw one quote from one of the first men who described chlorosis to say women should copulate and conceive, and then they would surely be cured. So diagnoses, we look back now, and we sort of go, what on earth was that? But I suspect we'll do exactly the same with some of our diagnoses today. Before I move on to a story about Hector, I would say that I thought with this book, I'm a neurologist, by the way, so I thought with this book a lot of what I spoke about or wrote about would be psychiatric diagnoses. And certainly they are there and they're vulnerable to these biases, but it transpired that much of what I wrote about wasn't about psychiatry. So we get a lot of bashing of psychiatry, but I think that's quite unfair. I think there are many disciplines that have questions to answer. So the next place I went to with this book, if we could just move forward a little bit to the 1980s. And if any of you were grown up enough in the early 1980s in this country, in the mid-80s, you would have remembered there were a lot of riots around at this time. And Handsworth was one of these places. It's in Birmingham. So I'll tell you a little bit about how this story came about. I went to a lecture at the Freud Museum. Have people been to the Freud Museum? I think there's a few attenders, yeah. And the Freud Museum in Hampstead, it's very nice. And there was a lecture there by a psychiatrist called Jonathan Metzl, and he was talking about schizophrenia. And I thought, right, I'll go along, because I knew I wanted to write something along these lines, but I wasn't quite sure what. And so off we went. We had this lecture from Jonathan, and it was incredible. He was showing how schizophrenia has changed over the course of decades. And between the 1920s and the 1950s, most people with schizophrenia, the poster child, were young, docile white women, middle-class white women usually. And they were women who were lovesick, or they just weren't behaving themselves at home. So the case note showed things like embarrassed her husband, talked out of turn, didn't cook on time, that sort of thing. But from the 1950s onwards, the poster child for schizophrenia completely changed, and now it was a diagnosis of angry black men. This was the time of the civil rights movement. And the diagnosis got applied to that demographic instead. And so you had members of Black Panthers, Black Power, Nation of Islam who were being labeled with schizophrenia. And if you look at the drug posters from that time, they change in parallel. So the posters from the 1920s to the 1950s were usually of women, basket weaving, gardening, for example. And the posters from the 1950s onwards were of black men standing in front of burning buildings, orange sky, with their fist clenched up in the air. And there were often words like primitive on there and ways to control, for example. And I wondered, I mean, I've included schizophrenia in the book, but I also wondered, was there some story that we could tell about the UK that perhaps hadn't been out there yet? But I wasn't sure what it would be. So I sent an email to Jonathan beforehand and said, are you around for a coffee to discuss this? And it turns out that works sometimes. And he said he was. And we went to Carluccio's and we had pizza and garlic bread. And I remember just saying, oh, I'm not sure if there's some other story here. And he reached into his bag and he took out 2 academic papers and he said, I'm not going to get a chance to look at these. Someone gave them to me, but, can you? And it turned out someone who I later realized was Suman Fernando, who's a psychiatrist. He's 90 years old, he won't mind me telling you. And he had turned up to that lecture, but he'd had to leave early from the Freud Museum. So he'd handed his stuff to someone else who handed it to Jonathan, and Jonathan handed it to me across the garlic bread. And in those pieces of paper, written in the 1980s, these journal articles, there were a few words that really caught my eye. And one was a place called Handsworth, which I hadn't heard of before. And the other was a diagnosis called cannabis psychosis. And so that's how I ended up in Handsworth, because I realized that's where the story was that I'd never heard of before. To get there, I also just had to cold call some people and ask would they just take me around Handsworth. So I called a photographer called Derek Bishton, who had lived there during the riots, and his photography from that time is famous. I also, or rather he put me in touch with a man called Hector, and Hector is also a local and lived there at the time of the riots. So Hector and myself and Derek walked through Handsworth on a very rainy day one day, and we were really a sight, because Derek's like 6'5". He must be 6'5", I can't really tell. And he's a white guy. And in the middle was Hector, who's originally, he came from Jamaica, I think, when he was only a kid. And then there was me. And so we were quite the sight walking through Handsworth. But in a way, we sort of represented the place a little bit, I thought, because Handsworth just has all sorts of everything. There are like shops called Chai Walla and Kerala Massage, and there was, jerk Caribbean chicken. There was all sorts of a range of stuff, and also shops that represented recent migrant waves. So, for example, there was a Slovak shop. And we got to a place that was a supermarket. And in 1985, when these events happened, it was a cafe. It was called Acapulco Cafe. And that's where the riots started, as far as we know. So there was an incident, and it's quite hard to know what happened, but there's some police reports I found from the time. And the police reports said that there was a man who'd parked a car there, and it didn't have a tax disc. And so when the police confronted him, this black man, ran into the cafe. There's disagreement about what happened next. There are accounts from the police that a number of men, black men, emerged from that cafe and confronted them, and missiles were thrown. There's also an account, and Hector told me this too, that there was a black woman who was knocked to the ground during that confrontation, but she never came forward to the independent inquest. What is very clear, though, is that the tensions escalated really quickly. So over the next 3 days, there was burning buildings, there was cars burnt right out, and there was many, many injuries also. And it made national and international news. It was in the New York Times. And by the end of those 3 days, there were not only dozens of people injured, but there was 2 men who had died. They'd worked in the post office, and the post office had been set alight, and they died from the smoke inhalation. So Derek told me, look, to understand these riots, because we often hear about looting and, it all seems quite mindless, but he was saying, look, to understand these riots, you have to understand Handsworth. So Handsworth was the most socially deprived place in the whole of the country. It had the highest unemployment rate. It was notoriously overcrowded. The New York Times said that 15,000 of 16,000 homes didn't even have a bath or a toilet. So these were the circumstances under which people were living. And I remember looking at the reports from employers at that time, and they openly said, not anonymously, that they would not employ people of color. They just simply wouldn't, and they put it right there on surveys without hiding their names. So these are the circumstances in which people were speaking out and fighting. And it's also important to say that these riots were multiracial. So the independent inquest found that at least a quarter of people taking part in those riots or protests were white, and a lesser number were Asian. But that's not how it was depicted in the media. And in the media, there was photographs of and headlines of things like Zulu war cries and prowling tribal riots, for example. But the diagnosis I discovered in the papers of the health authority at that time was one called cannabis psychosis. And I better talk about cannabis psychosis just very briefly in case there's some controversy about it. Does cannabis cause psychosis? Well, the jury is out to a certain extent. So we think there's a link between high-strength super skunk and mental health impact or psychosis. So that's less of an issue today in contemporary times, even though it's not cause and consequence. It's more of an association. Back then, people were smoking ganja, which is homegrown stuff, which is not what we're talking about here. But cannabis psychosis, the health authority said, was at the root of these riots. And this is why these men, and the black men, had very much decided to go out on the streets. They were drug-fueled, drug-addled junkies. And the health authority report said, this is an epidemic, we need to open more centres. And there was real panic in the community that this had suddenly broken out. So although there's controversy about cannabis psychosis, what's very clear is this was a racialized diagnosis. So it was made in black men in Handsworth. So looking at the records from Birmingham at that time, if you had psychosis, and by that I mean you're hearing voices or you're seeing things that aren't there, for example, or you're paranoid. If you were a young black man, 25% of young black men received this diagnosis in Birmingham. But if you were a white person, it was only 1%. The equivalent figure was only 1%. And this was even though white men in many surveys were actually taking more cannabis. They were using more cannabis than black men. And also black men weren't being tested for it, and even if they said they hadn't taken it, they still got the diagnosis. So it was clearly a racialized diagnosis. And I thought to myself, where else can I go and find this diagnosis? And I found it in the records of many places, but one that really struck me was Valkenburg Psychiatric Hospital in South Africa. And there was a study there that said 1 in every 3 Cape-coloured men, as they were described, has cannabis psychosis. And I had a further look, and I realized this hospital was racially segregated, and actually none of the white men were tested for this diagnosis. So the point is, you've got this community who are said to be angry and belligerent and hostile because of the cannabis that they took. That's why they were delusional and they were paranoid about their circumstances. And what struck me was cannabis psychosis allowed a narrative to form where their anger was said to be criminal or psychiatric or pathological, but it certainly wasn't legitimate in any way. And the consequences of that were profound. So Hector and Derek and I got in the car and we went up to a place just outside Handsworth, and this is it. This is called All Saints Hospital. And All Saints Hospital, as Derek told me, is that classic sort of Dickensian psychiatric asylum. It was a former asylum. Just outside Handsworth on rolling hills, there was a babbling brook nearby. And it had been closed down, but it was still attached to the prison next door. And this is where people were brought when they had cannabis psychosis during that time. And what Derek told me was that there was a connecting channel between the prison and the psychiatric hospital. So you could be brought to the prison, and then you could be walked through that connecting channel, and then you could end up in the psychiatric hospital, the former asylum. And cannabis psychosis was a common diagnosis here. So it's difficult to get figures, but from one snapshot, I found that 10% of black men had this diagnosis there, and in 420 white men, not a single one had the diagnosis. So what does this mean? What does this mean if you've got cannabis psychosis, and what sort of treatment would you get? Well, most psychiatrists in studies at the time and other doctors said actually you don't necessarily need heavy-duty treatment, but the reality is that many men did receive it. And the treatment black men were more likely to receive at that time, similar to now, they were less likely to receive therapy, and they were more likely to receive electric shock treatment and drugs. And that disparity, I suppose, around therapy being less frequently available to black men continues, and people of colour also. So this was the situation then. So it meant that black men were more likely to end up in this hospital and more likely to receive drugs. But the drugs they received were injection drugs. So they were heavy-duty antipsychotics that they'd received through an injection. There was one other study from Nottingham that showed that not only were these men more likely to get injections, but they were more likely to receive a higher dose, a peak dose of these drugs. And that caused a syndrome called tardive dyskinesia. Now, I don't know if anyone has heard, there's a few medics in the audience, I think. But tardive dyskinesia is a really stigmatizing disorder or syndrome that comes when you use these heavy-duty, old-school antipsychotic drugs. And I saw a man walk down the street towards us in Handsworth, and he had all of the features. So as a result of those drugs, even after you've stopped them, by the way, the syndrome could still endure. You get involuntary blinking of the eyes, for example. You get grimacing, you get chewing movements and tongue protrusion and salivation, and the people look like they've got Parkinson's, so they're sort of shuffling along and trembling. And this was a legacy of the diagnosis of cannabis psychosis. Eventually, cannabis psychosis was replaced by other diagnoses, like schizophrenia, for example, and I do talk about this and write about this in the book. But what was really striking is when I looked at the records of the All Saints Hospital just a few months later, there was no reports of cannabis psychosis. And in fact, the psychiatrist wrote to the BMJ saying there hadn't been any more diagnoses made, and it felt like it was sort of no longer required. It had been used to explain the events of the mid-1980s, and perhaps it wasn't really needed anymore. What I do want to say is, although obviously many of the things I talk about are very serious in the book, and you know, you sort of become a bit nihilistic when you think about some of these diagnoses, I suppose. But one of the really important things for me about this diagnosis was that you had people fighting against it. And as I said, many psychiatrists certainly either didn't agree with the invasive treatment of it or didn't agree with the concept. There was lots of disagreement. But what strikes me is that people can rise up within the establishment and speak out. And what strikes me also is that Suman Fernando, this 90-year-old psychiatrist, turned up to that lecture at the Freud Museum and passed over his academic papers from the 1980s. He spent fighting this diagnosis ever since. And those papers made it into my hands so I could tell this story. And that takes a huge amount of bravery to continue to fight this battle against these sorts of diagnoses, but he did. And Suman turned down an OBE in 2007 because he felt there was still institutional racism, and he wrote to Tony Blair to tell him what he thought of the offer of an OBE. I can only imagine what that letter said. And in a way, I therefore say, although Suman couldn't make it this evening, I thought I'd want to tell his story to say that we can affect change from within the establishment as well as outside it. So I'm going to move on. That's the story of Hector, who showed me around Handsworth. And I'm going to move on to talk about our final diagnosis, our final man, and that's Mikey Powell, who I'll come to in a moment. This diagnosis is one that required a lot of investigative work, and I didn't realize how litigious it might be and how tricky it would be to write about. So in advance, I thank the lawyer who read this book and went over my research, which I very much appreciate. This diagnosis actually emerged, or the idea for this story emerged when I was leaving Handsworth. So it was raining. I just remember it was raining, and everyone else had an umbrella, and obviously I had not prepared myself for Birmingham rain. And I was sort of wandering around some of the side streets, and I found somewhere to shelter under, and it was a fairly dilapidated building, and I wasn't sure what it was. And the rain wouldn't let up. And then I realized it was either a closed or about to be closed police station on Thornhill Road in Handsworth. And I was standing there and I was like, well, why does this look like it's going to be closed or it's about to be closed? It was a bit hard to tell. The doors were actually closed and there was some various signs up that said opposite things. So anyway, I looked it up and found out that in that police station, in the custody cell, there had been a death. A man had died in custody. And that man was Mikey Powell. He died aged 38. And it wasn't clear that that's why the police station was closing or was going to close, but rather that was one of the incidents that happened there, let's just say that. And when I looked up the inquest report, because you can find them online, so I was standing there and I just looked up the inquest report, and I saw a condition that I had never heard of before in my training, and it was called excited delirium. Now, we have a few doctors here. Does anyone, I think we have a few doctors. Has anyone heard of this condition before? No? Okay, so no. So not just me, no one does. So 15 years as a doctor, I'd never heard of it. And yet it was in all of these inquest reports, just time and time again. Excited delirium, someone died of excited delirium, excited delirium. The other phrases at the end of that sound familiar. They're the medical phrases. Coronary artery atheroma, left ventricular hypertrophy. I recognize those. Excited delirium. These UK inquests everywhere. And another one. And another one. And some of these reports have come thanks to the Bureau of Investigative Journalism. Charlie Mole is a reporter there, and some from the organisation Inquest. And I was wondering, what is excited delirium? How come I've never come across it? And it's everywhere. We did pathology, we learned how to do autopsies, we did forensics, and I still hadn't heard of it. And here it was, you know, in all of these controversial cases. And I thought, right, I'm going to have to go and find out where it came from. I'm going to have to try and discover this history. And in order to discover the history, I'm going to ask you to imagine Miami-Dade County, Miami in the 1980s. And this is where the diagnosis was born. So in the 1980s, there was a series of deaths in women. And there was 32 deaths in the 1980s that were all linked in some way. And these women were found in motels and in alleyways, outside car park lots, for example. And there was one medical examiner during all of that time, his name was Charles Wetley, who did all of the autopsies. And he decided all of these women had died of a condition called excited delirium. He also called it neural exhaustion at the time. And the idea was that these women had taken drugs, they'd taken cocaine, and they'd also had sex. Many of them were sex workers, the media reported. So essentially, the drugs and the sex had killed them, and they had this condition called excited delirium or neural exhaustion. At one point, someone else did an autopsy on a 14-year-old who was found in the same circumstances and realized there was no cocaine in her system. So then that same person went and revisited all of the other autopsies, and they saw clear evidence on these women of bite marks and asphyxiation and burns. They had all been murdered. And you would think at that point the diagnosis of excited delirium or neural exhaustion would go away. The police identified their suspect, and that man actually died before the trial could take place. But the medical examiner, pathologist involved in those cases, stuck by his judgment of excited delirium. So, as you'd imagine, excited delirium in those circumstances didn't really endure. But it turned out that another group of people commandeered this diagnosis. And it began being used by law enforcement. And there are now 800 uses of it a year in the States, but that's only the cases that go to court. So you might have heard it was applied to George Floyd, as you know, by the people who were defending, the people who were the officers who were eventually prosecuted for his death. There is another story here in the UK, and I am going to come to that later. But we still haven't got to the bottom of what excited delirium is. So I call my source, who is a medical examiner. I'm going to call him Greg because he didn't want to provide his own name for reasons that become evident when you talk about this diagnosis. And I said, right, if I had a cousin, let's say, that died in these circumstances and he had excited delirium given as a posthumous diagnosis, what would that mean? And that's, I suppose, the question that Mikey Powell's family had to ask. So he was the man that died in that police station. And I tell his story in the book because, of course, behind all of these accounts, you've got people, you've got families. And so I said to Greg, you know, if this happened, what would you tell me? And he said, right, I'd come out of the autopsy suite and I would say, your loved one died of excited delirium. And I said, okay. I would then say, well, what's the proof? Is there like a blood test you can do after someone's died? Or is there a biopsy? How do you prove it? And he said, oh, I can't give you any proof. I wouldn't be able to give you any proof. It's not a post-mortem diagnosis. There's no proof. And I said, okay, well, how do you define it then? And he said, we take the account of the people who were there when the person died. And I was like, who gives you that account? And he said, well, it's law enforcement, because they were there right before the person died. That's the only person who can give us a really solid history. So I said, okay, what are some of these features that the last witnesses are giving you? And here is a list from the National Association of Medical Examiners who recognize this as a diagnosis. And I've highlighted a few, but you can take your pick. Tachypnea means really rapid breathing, sweating, agitation, and what they call superhuman strength or unusual strength. And to me, this just sounds like anyone who's struggling against brutal force or trying to escape brutal force. I couldn't understand how this could be a diagnosis. And I also noticed the last two features are not ones that you tend to see in any medical diagnosis. Things like being inappropriately clothed and attracted to mirror and glass. And there was a few others I found. One was making animal-like unintelligible noises. And the other thing was just showing a lack of remorse before you die. That was one of the medical criterion. So this became a really popular diagnosis, as I said, and it was used in the context of those deaths related to restraint and law enforcement. And as you can see, it was used and continues to be used here in the UK, although it turned out from my investigative work that I'd really undercounted the numbers, and I'll come to that in a little bit. So the question for me was, if you have this diagnosis, and we look back at those Miami-Dade murders and we say, well, it made no sense, what are the things that mean it's still a diagnosis today? And the way I think of it really is sort of a crime scene triangle. I can't think of another way to describe it. But I'm thinking of three different forces in that triangle that are all influencing each other. So one of those forces is the police or law enforcement. And that probably makes sense because you've got these deaths under restraint. Many of these deaths in custody are specifically found to be because of restraint. So it's useful, let's say, to have a diagnosis or a label or a description to apply in these cases. So you can say it was excited delirium. I'm not saying intentions are always bad, but it's a useful label to apply in this situation. So that made sense to me initially, why there would be a force there for this label or description to endure. And then I thought, what about these medical examiners? What about Greg? You know, what's going on there? Well, we know that sometimes they work with or for the police, so there's, you know, that's maybe a link. But you can see I'm stumbling a bit because I still can't understand how you could still have this diagnosis, basically. And then I found out where the answer was. So you've got to go to Scottsdale, Arizona, and you've got to go up the freeway, and you've got to take one of the exits, and you've got to come to this futuristic building. And if you look at the website of this building, and it says, you know, jobs, what it's like to work here, you know, that section. And it says it's an open plan office. There are food delivery trucks every day, fridges full all of the time, and there's a roof deck garden with mist. There's a mist system, apparently, which is something we tend not to have here in Britain. And who owns that building? Who works out of that building? It's Taser, or Axon, as they are now called. They rebranded themselves to call themselves Axon. And Taser, if you can imagine you are working in that building, you probably don't want to see stun guns on an autopsy report. That is not the thing you want to see if you want to be proud of the work that you do. And I'm not saying, obviously, I'm not saying that stun guns are cause and consequence when it comes to deaths. I will say that if you look at autopsy reports in the States that mention excited delirium, you'll find 278 of them where stun guns were also used. A lot of this work, and very brave work, has been done by Reuters. They have a series called Shock Tactics, which I have to give a huge amount of credit to because they have spoken out when others would be too afraid to. And so think about how Taser, now Axon, might be linking in with these other forces. So we've got Taser at this bit of the triangle. They are going into law enforcement or police seminars. They're delivering hundreds and thousands of these, talking about excited delirium and teaching the officers about excited delirium. And they say, and they're very clear about this, they're just teaching people about excited delirium so that officers know to get medical help when it's required, when all of these features emerge. I went onto a website called policeone.com, and it's used by thousands of police forces in the US and elsewhere. And it's used by the NYPD, for example. And on this, there are a bunch of articles about excited delirium. It's everywhere. And, you know, as I said, I initially was ashamed I'd never heard of this diagnosis. And I looked at who had authored these articles. And time after time after time, I cross-referenced them and I found they were people on the board of Axon. There was one man, Mark Kroll, who's on there, who, when I traced his shareholdings, he had $3 million in Axon. And they are going into, you know, law enforcement and police offices and precincts telling people about this diagnosis. So then I thought, right, that's that bit done. What about the medical examiners? What's going on there? And I discovered that medical examiners are being paid tens of thousands of dollars to testify on behalf of Taser or on behalf of Axon. There was two other things. Some of the medical examiners call Charles Wetley one of their mentors, and in case you've forgotten his name, he was the man who did the autopsies in the 1980s in Miami-Dade County. But there's also another study that I thought was chilling, and it was a survey of medical examiner opinions. So medical examiners who are doing these autopsies have said that they are scared of getting sued. So 13% of them say they have changed their autopsy report because they were scared of getting sued, and for good reason, because some of them have been sued. A third say they will change their reports in the future because they are scared of getting sued. So that's a third of medical examiners. So the triangle for me sort of seemed to now make sense and would explain the 800 cases a year that we know about, but not, we don't even hear about all the others. So I decided to come back to the UK and figure out what was going on here. And I didn't realize it would intersect with very recent events, including a statement by Priti Patel just a couple of weeks ago. So excited delirium is a diagnosis that I thought, why are we not seeing as much in the last couple of years as before? And then I found out it has been relabeled here in the UK. So this is the Royal College of Emergency Medicine. This is their recent statement. And you can see acute behavioural disturbance, previously called excited delirium, is an umbrella term, and it's used to describe a presentation which may include abnormal physiology and/or behaviour. It's important to recognise that ABD should not be considered a diagnosis or a syndrome. So I've been told I must say it's a description and not a diagnosis. But rather it's a clinical picture with a variety of presenting features and potential causes. It's widely recognised, both in hospital and pre-hospital emergency care providers and by the police. That's acute behavioural disturbance, or ABD, and I started to search inquest reports of police custody deaths, and this is what I'm finding everywhere now. Here are the features, and I'm going to just let you have a read through those. All right, let me go on. So some of these might sound familiar to you. So I'm going to sort of go through them and do a bit of a comparison of excited delirium and ABD. So agitation is present in both. Here are all the criteria present in both. Inappropriately clothed, I've put a star on the end of that because it's not present in that document, but it's present in all the training materials and various police websites that have been updated in the last 4 weeks. And the same for lack of tiring. The inquests occasionally use excited delirium and ABD interchangeably, and there are a couple of new ones in this Royal College of Emergency Medicine guideline, including that the person is fearful and panicky before they are either taken to hospital or they die. Now, one of the arguments around excited delirium was that it helped to identify medical emergency. So if you saw those signs, at least you could stop restraining the person and maybe call medics. And the word medical or emergency appears 40 times in one of the first documents outlining the criteria for this. And so, that might feel quite comforting, but how can you get to a point where you restrain someone so much that you then see signs that you have to call for emergency help? And that's exactly what's been used with ABD. That's the same sort of argument that's been used to support ABD now being used. And there are even some lawyers who are defending, who are rather acting on behalf of families, let's say, of some of these victims who support the term, but I'm not sure if the word is out there of these parallels. The Royal College of Psychiatry in recent years have acknowledged many things that they would do differently now, and they came and they spoke out against this diagnosis last year. There was a statement on their website saying that they had serious concerns, that they said it had no empirical evidential basis. Very quickly, the Police Federation came out and criticised that statement. It called it a hugely damaging article, and it said it could impact negatively on every police incident involving individuals with the condition. Essentially, they told the Royal College of Psychiatrists to stay in their lane. As you can see, the Royal College of Psychiatry is a charity. It should focus its energy and attention on areas it has expertise in, rather than issuing factually incorrect, politicized statements. Our members are owed an apology for this, and we will be referring this to the Charity Commission for England and Wales. The Royal College of Psychiatry have now taken down their statement. There was something else I wanted to say about ABD, and I'm going to go back. This is acute behavioural disorder, and I was wondering who has authored this guidance in the Royal College of Emergency Medicine. And the person who has authored it is also the medical director for the Metropolitan Police. So that's the person who is writing this guidance. Is there another way instead of using these diagnoses? Of course there is. And one of those is street triage. I mentioned Mikey Powell earlier. He's the man who died in custody. He's also a 38-year-old father of 3 who liked blues music and reggae, and I tell his story in the book. And his story comes to me from Tippa Naphtali, who's his cousin, and I also have the words of Benjamin Zephaniah, who you might recognize, who was also Mikey's cousin. And they have joined forces, and they have worked with the West Midlands Police. The West Midlands Police, by the way, have denied liability for Mikey's death. They have apologised for the pain and suffering caused to Mikey's family. But they have worked together to create a street triage team, which means when someone is experiencing a mental health crisis, as Mikey was, and Mikey didn't hurt anyone else, he put his arm through a window, he didn't hurt anyone else. He was restrained by 8 officers for more than 15 minutes before he died. This street triage team turns up to someone who's having a mental health crisis, and they don't come in a police car, they usually come in an unmarked car or an ambulance, and you've got police officers who are trained in mental health, as well as a mental health nurse, usually, and a paramedic. And Tippa tells me that since this team was set up, in his area, there hasn't been another in-custody death case like Mikey's. So there are other ways to approach this, and I don't believe a diagnosis like acute behavioural disorder is one to use. I'm going to draw to the end of my talk now. I know we've talked about 3 men, and their stories are really, I thought, crucial to demonstrate what diagnosis can do. I do want to say, you know, I spent 15 years as a doctor, and this book really isn't an indictment of the medical profession, and a lot of it is how doctors themselves have spoken out, as well as those who are diagnosed, of course. But I do think it's important to, I suppose, scrutinise the diagnoses that we make, because they can be used for all sorts of purposes. And I was thinking, you know, if you're ever lucky enough to buy a house, you go and you get a building survey and you see what the cracks are and what the flaws and the fallacies are. And I think we should do the same thing with our diagnoses. We should hold them up to the light and see what the flaws and the fallacies are and the breaks that need repairing. And my hope is if we do that and people speak out, both the people who are diagnosed and those who make the diagnosis, that when we're sitting in triage with our minor injuries, hopefully, that we can be led away from harm and from hurt and hopefully towards care and towards compassion. Thank you very much.